Um, Thank you so much, Sue, for inviting me this evening to talk at Maternity and Midwifery Hour. And I'm absolutely delighted when Sue contacted me to say, would I come and talk about the care of migrant and refugee women, because this is something that's really close to my heart. And I'm not going to go through all of the embrace statistics, because I think we're all quite familiar now that if you're from an ethnic minority background, you are statistically more likely to have a stillbirth, neonatal death, and maternal death. And they're very complex reasons as to why that happens. But hopefully by the end of this presentation this evening, it will just give you a bit more insight as to why that happens, and what, as midwives, we are advocates for women, what we can do to help reduce that. So this presentation is going to be a bit of a mismatch between my care that I've been given for women that have fled from Afghanistan, and also how we can just generally reduce health inequalities for migrant women. So before I start, I just wanted to sort of say that this is my reflections on Tulip Team. And for those of my colleagues that are watching, they know that I'm very passionate about my Tulip Team, and I get very sort of mother hen about them. And the reason we called the women from Afghanistan Tulip Team, I didn't like when people are handing over, oh, this is a lady from Afghanistan, or she's an Afghanistan refugee. I felt that it was a little bit demoralizing, not quite personal. And so I came together with my colleagues and I said, what team could we call the women from Afghanistan? And I didn't come up with this name, so I can't take credit for it. It was one of my colleagues, Rebecca Taylor and Daga, and they said, tulip is the national flower of Afghanistan. And I lived in Amsterdam for a little while, and I always associate tulips with Amsterdam, but actually tulip is the national flower of Afghanistan, and it means hope and love. And I just thought that after everything that the refugees have been through, so nice to call them Tulip Team. So I just wanted to sort of start off with that. So before I go into how I got involved and how we provided care, I just wanted to talk through a couple of things about unconscious bias. So these are sort of snapshots of headlines that I've screenshotted for you here. And I really dislike the term illegal immigrant. And you'll see that quite a lot in the news: illegal immigrants, people smugglers, trafficking illegal immigrants. And the reason I don't like it is because, as you see in this picture up in the right-hand corner, and this was a protester in Mexico, that no human being is illegal. And talking about somebody in the terms, if you see somebody saying, oh, this is an illegal immigrant, it already sort of sets those unconscious biases within you that this person's a criminal, they've done something wrong. Now, this gentleman here, Elie Wiesel, he was a Holocaust survivor, and he fled. He was a Jew, and he fled Palestine, and he's a Nobel Peace Prize winner. And he was the first person that said, no human being is illegal. And I've just got his quote here. And this sort of term, illegal immigrant, was really used. This is where it came from in World War II. And what he said was, no human being is illegal. Humans can be beautiful, more beautiful, fat or skinny, but not illegal. It is factually incorrect and dehumanizing to call somebody illegal. It only serves to perpetuate the idea that migrants are criminals. So I just thought that was, really quite powerful. And he did a lot for the rights of migrants. So I just put his photo up there. So thinking about unconscious bias now, when we think about the disparities in outcomes for migrant women, it's really complex as to why there are disparities in outcomes: stillbirths, neonatal deaths, preterm births. But one of the things that we often see when we're sort of reviewing adverse outcomes is unconscious bias, and they're really difficult to pick up. But I just want you to think about how your unconscious bias might play in to when you're caring for anybody. Now, what I would say is that it's unconscious, so we're not consciously doing this. And your brain is so clever. Your brain is doing 101 things at any one time. Even when you go and open the door, all of the signals that have gone through your brain to open that door. And to do that, your brain has to be really quick and adaptable. And usually your brain does that from memory. And it does that because it's doing it from memory of what we think we know, and not necessarily what we know. And we've just got a sort of a slide here of different infographics of how unconscious bias does impact your care. So you can have affinity bias, so preference for people that are like yourself. We make assumptions, and I'll just come on to a bit later on in the presentation of how I made an assumption unconsciously, and it gives a good example of how we can sort of navigate that. So I just wanted to say that before I start. So thinking about women who have come from Afghanistan, what I would say is 1 in 4 migrant refugee women are women of survivors of sexual assault and sexual violence. And I think as midwives, it's really important that we're really mindful of that. Obviously, we're often doing really intimate examinations. We're taking intimate history taking. And often women, they don't disclose this, or they don't disclose it immediately. Again, refugee women are often at high risk of exploitation. So some women, if you class them as, I don't like the term illegal immigrants, so undocumented migrants, these women often aren't entitled to free NHS care, which puts them again at risk of sexual exploitation. So as midwives, we really do have to be mindful and sensitive to these issues, which do present themselves more in the migrant population. So just a little bit about the Afghanistan refugees, TULIP team. And I'm sure you'll probably all know that obviously there was a massive sort of relocation program just going on recently, and we have accepted 15,000 refugees between the 15th and 31st of August, and they were sort of categorized into 1 to 4. So most of the migrant women who have come over in the initial period are in the high risk and immediate threat category. So this means that women are going to be extremely frightened. They're going to be very fearful for their families. And when I was doing the antenatal clinic for these women, nearly every single woman through the interpreter said that they were really scared for their family. And you could see that they actually weren't really concentrating on their own health because they were so preoccupied and worried about their families back home. So just something to think about when you're looking after migrant women. So how did I get involved? So just as a little bit of background, so I work very closely to a quarantine hotel, and we'd had a few women go into the quarantine hotel, and I'd sort of received really good links with the GP practice manager that was overseeing health in the quarantine hotel. And she called me really late one evening, about 10 o'clock in the evening on the 24th of August. And I thought, this is a bit of an unusual call. And she called me to say that they had just had 700 arrivals into the hotel, all from Afghanistan. And several of them were pregnant, many in various stages of pregnancy. They were all exhausted because they had been traveling for days. And we sort of had this sort of really quick meeting at 10 o'clock that night to sort of say, okay, how are we going to triage this many people, often not speaking English, might not have had much maternity care. So overnight, with lots of conversations with my obstetric colleagues, we put in this process of emergency triage. So we said that what we're going to do was go in the next morning and do a sort of an initial assessment. So with the refugees arriving in the hotel, they were asking them, what medical conditions have you got? Are you pregnant? And then the ones that were pregnant, they were sort of booking them in for us to see them the next morning. And what we said was we're going to do a sort of initial assessment. If they were bleeding or pain or reduced fetal movement, then obviously we'd need to sort of transfer them to hospital. If they were in the 3rd trimester of pregnancy, or they had sort of other known sort of medical complexities, diabetes, high blood pressure, and we did come across that, and they didn't they didn't have medication with them because they'd sort of fled in such a hurry, then those women we would refer as well. If they were early on in the pregnancy, then we would see where they were going and sort of get their midwifery booking arranged. Now, preparation, what I would say is absolutely nothing prepared me for what happened for when I went into the clinic the next morning. And what I would say is I was brought to tears about 3 times during the clinic. And when we actually did the clinic the next morning, and you might remember on the news, this was when the bomb went off at the airport, and it actually went off in the middle of my clinic. And obviously women were getting notifications and were so worried about their family. And the level of kindness that I saw from the people inside the hotel that were trying to help the refugees, but also from the women themselves. So I saw one lady and she had a bangle on her hand, and these women were coming with no shoes. A lady even asked me if I had a hairbrush on me. If I had a hairbrush, I would absolutely given it to her. And so then I saw her, checked her over, and everything was fine. And afterwards, she tried to give me her bangle. And I was just brought to tears that this lady had the clothes that she was wearing, had left everything behind. And the one thing that she did have, she tried to give it to me. And I was very insistent, and the interpreter was telling me, it's really disrespectful not to take her bangle. This is sort of what they do. And I was really adamant. I was like, I really can't take it. I said, because I'm just going to cry all the way back to the hospital if I take it. But so I'm just saying that nothing could absolutely prepare me. But I think going into this situation, what we did do was sort of the best preparation we could do. We downloaded lots of leaflets in Pashto. Now, what I hadn't appreciated, and I thought I was being really clever by getting loads of leaflets on reduced fetal movement, bleeding, what maternity care in the UK in their sort of dialect, but about 50% of the women I saw didn't read or write, and I hadn't appreciated that when I went in. So I think never go in with your, we always say, or make sure you get literature in their own language. And I think we take it for granted often that that women are fortunate enough to read and write. And obviously the women that we were seeing when they had the regime in Afghanistan back sort of 25 years ago, women weren't allowed to go to school, and that's why women couldn't read or write. The other thing we thought about before we went into the clinic was about vaccination for these women. So things like polio and rubella. So we know that polio and rubella is high in the Afghanistan population because they don't have a good child vaccination program. So we were thinking, when we're thinking about booking bloods as well, adding in rubella, and obviously that's not part of the national screening program in the UK. That was removed a few years ago now. But we did add that in for the women that we booked in Tulip team. So when we went in and did the clinic, so we sort of had an initial triage pro forma that we went through, and we worked alongside a local GP, and it was absolutely great to work along the local GP, because women had sort of very sort of common minor elements that the GP could prescribe things for. And there was one lady there who had thrush, and she reported being in the same clothes for the last 4 days because she'd been stood up at the airport. So there was some really sort of sad stories, and as I say, I did have to sort of stop myself crying a couple of times. So of the 16 women that we triaged that morning, we referred 3 to hospital under the urgent pathway. And 1 was because of their late gestation. 1 was due to her medical history. So she was hypertensive and didn't have any medication with her. And then a 3rd lady had vaginal bleeding. So the first 2 ladies delivered within a week, and they both had baby boys, healthy baby boys, and they were fine. And the 3rd lady that had the bleeding had a cervical assessment and prophylactic anti-D. Interestingly, when we referred these ladies to hospital, all 3 ladies self-discharged. Now, what I would say is, think about why these ladies are self-discharging. It's not because They don't want care. There's many other factors going on. They're scared about what's going on. They've got other children. They're very frightened. They don't want to be separated from their children. Children staying in the quarantine hotel. They're staying in hospital. And obviously we've got all of these new COVID regulations now. And obviously they were in a quarantine hotel, so the children can't leave. So it's got that logistical government rules of, you're only allowed to leave hospital if there's a medical reason to do so. So when women are self-discharging, and this infographic here comes from the RCM have published guidance last month on caring for vulnerable migrant women, and it's a really good guideline. And this is sort of a snapshot from their guideline, and it's sort of check their understanding, ask about possible barriers. Is there anything that you can do to, can the children come in once they're out of quarantine? Thinking outside of the box, not just simply saying, oh, we're not having any children anymore. These women are really vulnerable, and thinking about what we can do for those ladies. And obviously using interpreting services to have those conversations. Now, hopefully you can see this. And I just wanted to sort of bring this in when we're thinking about women that are self-discharging or not accepting care. So for women from Afghanistan, if you have a look on this top bar here, so the second one in is the coverage of antenatal care. And this is from the World Health Organization. So 63% of women have one visit from a midwife. So when we're thinking here about how much antenatal care we have, and the reason for that is, antenatal care is sort of preventative, it's public health, we're reducing adverse outcomes. The women are not used to seeing midwives. They're not very common. And when you have a look down at the bottom here, this is the density of doctors, nurses and midwives and pharmacists amongst the population. And Afghanistan have the lowest number, one of the lowest numbers in the whole world. So they haven't got this flourished staff of midwives or doctors. They're not used to seeing them. So just when we're going on, you need to come for this visit, you need to come for this scan. The women say, well, I only saw you last week, or I only saw you 2 weeks ago. So, this is just thinking about having that outward mindset of why is this woman accepting or declining care and thinking outside the box. So for the women that I saw, those 16 ladies, as I say, 50% didn't read or write, and the majority were not aware of their LMP or EDD. And this really, I wasn't expecting this. I was really expecting every woman to sort of know their LMP at least. And I think probably the reason that lots weren't aware of their LMP was maybe because they didn't read or write. So thinking about calendars, it was very difficult to take a history. They were very accepting of their healthcare outcomes. So there were a couple of ladies that I saw that had previous neonatal deaths, and they weren't really sure what had happened in those pregnancies. They were very young. So the mean age was 25 and a half. And 3 out of those 16 were multips. And then if you just have a look down at the bottom here, and I just find this staggering. So if you look at on the right-hand column, the maternal mortality ratio, so the maternal mortality is 638 per 100,000. So if you compare that to the UK, it's 8.8 per 100,000. So, it is common in their population that they will probably know people that have died during childbirth, which adds another dimension of fear, of uncertainty, of perhaps not trusting of services. Everything is not what it seems. So I'll just put this in. So this was taken from a news clipping a couple of days before the refugees arrived. Now, the first lady who I saw through the interpreter started telling me that she had a sore leg, and it was, painful. And the first thing I started thinking was, has this lady got a DVT, pregnant, long haul flight, traveling? And when I spoke to her in more detail, actually she'd been stood at the airport for 3 days, and she didn't want to lose her space, so had stood up for 3 days. And then I spoke to the next lady, and then the next lady, the first thing she started saying was, my legs are really hurting. And every woman I saw kept saying how painful her legs were. And I just want to sort of So, you know, these women really have been through some just unimaginable circumstances. And I hadn't appreciated sort of their journey immediately before they had travelled. The Islamic calendar. So when I say about unconscious bias, and this only dawned to me halfway through the clinic, and it's really important for those of you that are, and this is one of the main messages for those of you that are watching, that are caring for women from Afghanistan. All of the women that I saw, as I say, they didn't really know their EDD, but when you ask them how many weeks pregnant you are, they go in months, and they go by the Islamic calendar month. And I was very cross because one of my best friends, known her for 20 years, is Somalian. And I said to her, in 20 years, you never taught me about the Islamic calendar. But the Islamic calendar is, depending on what year it is, it's actually 2 to 3 weeks shorter than the Gregorian calendar, which means that, so if you're then directly sort of, if somebody says that you're 7 months and then you're directly sort of converting it into weeks in the UK, actually the woman could be further ahead than you think she is. And this is really important because somebody could say be 42 or 43 weeks and you think that they're 40 weeks. And obviously, you know, we know that if you go sort of that far post dates, you're at risk of stillbirth. So I really wanted to sort of hone that message in. Thinking about cultural humility and cultural competence, I would like to say that I'm sort of a culturally competent person. I've been sort of campaigning for migrant rights for sort of the last sort of 5-6 years, but I'm very acutely aware that I'm sort of a white, you know, educated woman. So I just wanted to sort of talk about the difference between cultural competence and cultural humility and what that means in practice. Now, cultural competence, it sort of implies a discrete endpoint, that if you're competent, you know, you've ticked that box, you're culturally competent, and that's sort of that's the end. Whereas cultural humility is really thinking about it's self-reflection, it's thinking about your background, where you fit into society. It's going much deeper than just thinking about somebody's culture. It's thinking about your background and how that fits in to that person's culture. And this was a really good quote that I saw, and it says, cultural humility is the practice of self-reflection on how one's own background, experiences and expectations impact a situation or interaction. And the reason I say that is, when I think about the you know, as I say, the way I was calculating the EDD, and I didn't realize until halfway through that I had done it incorrectly. And I was assuming that, well, this is the right way to do it. And this is how we do it. And this is how everybody does it in the world, that this is how you calculate pregnancy. And that's not the case. And this is what most of the women from Afghanistan were doing. So coming on to sort of thinking about cultural humility, it also requires historical awareness when you're thinking about caring for vulnerable migrants. And this was Ernest Hendon. And those of you that might know this man, so he campaigned for the Tuskegee workers. And I don't know if you were aware of the Tuskegee experiment that was done in 1932. And this was where Tuskegee men, 600 of them, were enrolled into sort of a free health program. So the sort of the health service at the time said, we're going to give you free healthcare and you're going to have free meals. And excellent, they all signed up to it. Half of the men had syphilis. And obviously untreated syphilis is terrible, can cause blindness, liver disease, you know, really you can die from untreated syphilis. And what the researchers wanted to do was see what the course of untreated syphilis, how that panned out. So they didn't tell the men that they had syphilis. And this was just absolutely awful. So when we're thinking about not necessarily women from Afghanistan, but from migrant women, sometimes they do have a distrust of healthcare services. And I think it's really important that we understand why some people are really distrusting of healthcare services. And this is where this history comes from. So moving back on to our Afghanistan refugees, I've heard a few people say, "Oh, these are the Afghani ladies," and that's really not correct. And I think terminology is so important. And Afghani is the language that they speak, and it's not the person, which is why I really liked the term from Tulip Team. And then I just wanted you to think about what's your language behind your veil. So I just wanted you to sort of just sit back for a minute and just imagine that you were sort of picked up from your home and you were transported to Afghanistan, where you didn't speak the language, heavily pregnant, you couldn't read. Just imagine how vulnerable you would feel. And in my career, not for women from Afghanistan, but in my career, I have seen people sort of shouting at women that don't speak English, thinking, well, you can shout as much as you like, they still don't speak English, and that can come across as quite aggressive to the women. And most of it's body language, isn't it? So even if you don't speak the language, you pick up on all of these cues, and maybe then you wouldn't say that you're suffering from domestic violence, or you weren't sure if your baby was moving. So it's really important that we connect with these women on another level. And I just wanted to say this, that we should all be having interpreters now. We've got at our hospital where we work, and it's excellent, I use it all the time, we've got an interpreter on wheels. So it's like a little iPad, and you just and we've got loads of languages on there, about 80 languages, and you can just sort of click on it and it dials through, and you see somebody come up on the screen, and you can have those conversations. So we really shouldn't be using family members now. Children are inappropriate sometimes when you're having really difficult conversations about maybe, are you having vaginal bleeding? When did you last have intercourse? It's not appropriate to be using children for those conversations. And also, there is sort of a higher prevalence of domestic violence in this population. And if you're using partners, then how are you having those conversations? So this is like a whistle stop tour, because I could honestly be talking about this all night. So what would I do differently next time for the care of these ladies? So I would definitely attend with perinatal mental health. So obviously, when we sort of arranged this sort of emergency clinic for the next day, it was sort of all a bit frazzled, and we did it overnight. I sort of spent the most of the night up sort of trying to arrange this antenatal clinic the next day, but we definitely should have gone with perinatal mental health. And I think lots of these women were suffering from post-traumatic stress. They were really frightened, and obviously the bomb had gone off during the clinic, and definitely having those psychological support systems in place. One of the ladies that I spoke with, she was very young, she was 20 years old, and she'd come to the country with her husband because he was an interpreter, and the rest of her family, her brothers, her sister, her mum and dad, were all at home. And she's absolutely just, you could just see that she was so frightened. And these women do really need that extra perinatal mental health support. We need to be caring for them and asking them all of those questions, obviously with interpreters. And then a debrief for myself. I was so busy in the sort of the weeks after caring for these ladies. We did all the caseload for them whilst they were in the quarantine hotel, so that they were in the hotel for about 14 days. So quarantine is for 10 days, but we were sort of waiting for the Home Office to relocate them. So they were with us for about 2 weeks, and we were providing all of the antenatal care. So I was sort of too busy doing all of that, and didn't debrief myself. And I think it's really important that, and Sue mentioned it at the beginning, that we have got a really tough job at the moment, and I think we often don't stop, and we reflect by ourselves when we're driving home or on the train, but having that sort of time out to speak with your PMAs, having that restorative practice, that's definitely what I would do next time. And couple of resources for you all. So I mentioned it already about and I think Sue's going to put them up, the RCM guideline on caring for vulnerable migrant women. and then maternity actions, improving access to maternity care for women affected by charging. And what I would say is all of the women who have fled Afghanistan, the Afghanistan refugees, obviously they're seeking asylum, so they are entitled to free NHS care.